Thank you, Dominic. Just one comment. Shanker's face may be described as fuzzy. You'll find that my thinking can be described as fuzzy as we go through the comments in the next 20 minutes. Pleasure to be here, and I'm going to cover this topic as well as I can at the depth that we can in about 20 minutes worth of time. I'm going to give you some examples and some technologies and issues that we face at Partners Healthcare, and just a bit of that. We're a large system of care founded by the Brigham and Women's Hospital, the Massachusetts General Hospital. We also include the Dana-Farber Cancer Institute, a series of community hospitals, 7,000 physicians. We see about 4 million outpatient visits a year and 160,000 admissions a year. So we cover the gamut of very academic to very frontline primary care. And the material here is stuff that we talk about in effect within the course of our trying to leverage the technology to improve care. Focus on some examples which you can, technology which you can see today, so one can find them in use, but nonetheless use is relatively modest and adoption is quite low. And it can be low because the technology is immature and hence still has a ways to go before it can be widely deployed. It can be low because the business model is immature or unclear, and so it's not quite sure how to make money at it or why you would invest a lot in it. It can also be low because society and the change process hasn't moved rapidly enough. I mean, it takes time for physicians to adopt and for patients to adopt, and we can be early in that curve. I picked 3 categories, but only 2 that I'm going to talk about as sort of examples of this communications and ubiquitous computing. The first is the notion that you deliver care remotely, over distance, asynchronously, to someone who is not with you in the provider, and we'll look at some examples of that. The second has to do, relatively hot, as they say, of the wireless infrastructure within the walls of an organization, the campus of the Massachusetts General Hospital, for example. The third, which I won't talk about, we may cover later on, is the creation of regional and national exchanges of clinical data, so between organizations over distance and again, spanning organizational boundaries. So I'll focus on the first 2 largely. In our sort of view of the world, there are 4 categories of remote provision of care. The first is relatively routine transactions, and this might be me looking up information on the web to learn more about a disease or a medication. It might be conversing with my physician to refill a prescription or to ask a question about an illness that my child has. Relatively routine, although I might be quite anxious about them, but routine transactions with the care provider team. The second is the monitoring of someone with a chronic disease. I suspect you all have seen the statistics about the growth of chronic disease. 50% of the adult population in the States has a chronic disease, and as we live longer, sooner or later we will die. I mean, that's sort of, I don't mean to break it to you, but we all will. And it's kind of a downer early on in the conference to inform you of that. But nonetheless, we will all have these diseases for long periods of time, and to monitor and to detect deviations from acceptable existence and to support the patients in their efforts to monitor the disease. The third is the monitoring of an acute episode. We are under, and a lot of places are, enormous pressures to get you out of the hospital, partly because the reimbursement is structured there, partly because we are at capacity, and we just need to keep moving people out. And so in a lot of work in our case now of early discharge from post-operative care, and then monitoring the healing of the wound, monitoring your return to normal daily living, but to make sure we can get you out of the house in a safe and effective fashion. And then the fourth is where one needs access to a specialist. And this can be a primary care provider who wants a consultation with a neurologist or a dermatologist or a cardiologist. It can also be the seeking of a second opinion. And so you have cancer, you've been rendered opinion, but you want to make sure that, in fact, this is perhaps the best that we can do. I'm going to give some examples of these, both screenshots and some examples of why or sort of value of these, and then we'll talk about some of the areas we're working on. This is, and you may all be conversant with this. This is an example, and Paul Tang has done a lot of work in this area, of a website that links me to my physician's practice. And you can see on the sort of middle bar there, access to my record, requesting an appointment or a refill, or seeking health information. Second here is an example where on the far top left there's a gentleman with lesions on his back. The primary care provider has taken a picture of the lesion here and transmitted it to the dermatologist, in this case at the Massachusetts General Hospital, for interpretation of what is going on here. We find our primary care providers have a 50% chance of getting it right when they do their own attempt to diagnose what is going on in dermatological cases. This is an example relatively common these days of remote monitoring. On the far left is being used to control or monitor sort of diabetes care and others, and on the right is a sort of general purpose ability to hold a sort of two-way video conference and looking at data. So these equipment are here today. We try some of them. Last example here is where you can request a second opinion. You could be as far away as Beijing, Sao Paulo, or Dallas, Texas, and we'd be delighted to give you an opinion about particularly a lot of cancer work, but also a fair amount of neurological work that goes on here. Now, why this and why the interest despite the low penetration? Teledermatology, our work that's done, is that the dermatologist is 3 times as efficient. They can see 3 times as many skins per unit time this way than face-to-face. And largely because there's no social overhead of saying hello to somebody you've never met who's half naked and has something disgusting on their skin. You simply look at the picture, you render an opinion, you move on to the next. And so there's conversations with the payers about dropping the reimbursement rate by 50%, and we can literally make it up on volume in this case. And patients like it, and you can get quicker resolution of the issue. So there's an efficiency argument here. There's another efficiency argument on remote monitoring. This is from congestive heart failure cases, where you can see unmonitored, where the nurse has to go out more frequently, and then you can see monitor where there's less frequency. So there's a 33% gain in the productivity of the visiting nurse. Very hard to find visiting nurses. It's a high burnout profession, so one can increase the productivity and obviously lower the cost associated with that care. And then the last example is where we get second opinions. There are about 1,000 cases where we change the diagnosis 5% of the time, which is a seriously big number if you are in advanced forms of cancer and you've been misdiagnosed up to this point. And where there were material changes in the care plan 85% of the time. And again, you can see the preponderance of oncology work that's going on here. In these cases, by and large, a lot of these, the technology is fine. To talk to your physician through the internet, the technology is reasonable enough. The area where it is the most volatile at this point, in some ways the least mature, is monitoring of the chronically ill and to a degree the post-acute. 2 examples of devices here. This is a device from Ristech to monitor blood pressure, and it works, but it's, quote, almost inconspicuous. And that's hardly almost inconspicuous. It's about as conspicuous as it gets. And then even there's no ability to communicate with any broader infrastructure, so that one has a sort of whatever one wanted to do on a real-time basis here. Here is a glucometer on the wrist, which is almost good enough to replace the sort of normal finger stick, but not good enough to replace that, and again with no communication ability. So we have folks, and you may have folks too, who are spending a lot of time on sensor technology and measurement technology to make them less conspicuous, less expensive, battery life lasts longer, and to have some reasonably robust communication abilities. In addition to that, there's this phenomenal explosion of portable form factors and knowing how best to leverage them in the treatment of patients. So an example, we have a trial now, and I'll give you the sort of business background here. If you want an appointment with a dermatologist at the Massachusetts General Hospital, you have 50 days from now is the first available appointment. That's as quickly as we can get you in. And this is not useful. And so you look at, well, what's clogging up the calendar? I mean, what are these appointments like that exist now? A lot of them are routine review of acne. Fundamentally what it is. Now, if you're 18 years old, this is a terrifying, life-threatening issue, and you may not get a date, and that's how serious this is as we deal with it. But you come in, and by and large, you maintain your antibiotic regime, or you change it modestly. What we're experimenting with now is you use your cell phone with a camera, which every 18-year-old has. You take a picture of a skin, you transmit it to the dermatologist. They'll tell you whether to continue to do what you're doing or come in and we'll change you from erythromycin to some amoxicillin or whatever. So these are examples of experimenting with these devices, and a lot of these of getting care out of routine, non-acute settings and dealing with them remotely. We want to, as a service, Second, we would just as soon get rid of you, which is a low-fee visit, and replace you with a high-fee visit. And if you have a 50-day backlog, there's a lot of high-fee visits that are waiting to replace that slot that we've just filled. So experimentation with the leveraging of these, which people carry anyway. 18-year-olds carry cell phones with cameras anyway, and they're getting increasingly more sophisticated. So a fair amount of experimentation and learning about these. The second is the notion of the home as a hub for monitoring routine diseases. We have a trial now with a bunch of folks, largely people who are not elderly, but middle-aged with chronic disease. So this can be depression, this can be obesity, these can be diabetes, et cetera, and leveraging the home. Now the question becomes, what is the hub in the home? And you have a lot of alternatives here. You can have the TiVo box set, the wireless network, the cable plant, et cetera, and try and understand what's the best platform or how one adapts to a series of platforms in the home to essentially deliver a hub, which can do a variety of things, although it's not quite clear the role that the hub actually ought to play in this regard. So we spend time here where the technology is the most volatile and in many ways the most immature. This is a situation of volatility. This is early stage home penetration of intelligence, and that's why you see the diversity that you do. We also work on the business model. As interesting as the technology might be, it may go nowhere unless there's money to be made by you all and money to spend willingly on our part. So we have some different models here, and we'll touch briefly because I'm getting the count here. One is the chronic disease, both reimbursement that's fixed, getting fixed assets, whether they're nurses or you out of the clinic, because clinic is a finite physical construct. One of the reasons for early discharge is to backfill you with other cases, again with higher consumer or higher payment early on. And also access to specialists, where we now offer it as a retainer employee benefit to Fortune 500 companies with staff all over the globe who want to make sure they have access to the specialists if they're based in parts of the third world, for example. So a lot of work on the business model. Let me move quickly into the wireless realm. Three major categories or reasons here. One is the workstation extender, so rather than sit on my workstation, I can carry on these transactions somewhere else. The second is for the staff to communicate within the provision of care, so walkie-talkies or instant messaging. The third is to track things, broadly defined. This is some data from 3 units on the Massachusetts General Hospital inpatient setting. Units are in the columns. In the course of 1 hour, a lot of communication goes on, or attempted communication between nurses and doctors, incoming and outgoing, highly inefficient. A great deal of it is missed, and the effort is to drop some of this, but also increase the efficiency by which it is handled. There may be no immediate ROI in this sense, but nonetheless, if we can reduce the hassle of the nurse, it is phenomenally important to us. So looking at technologies to alleviate this situation. Here, a little bit busy, we lose equipment all the time in the hospital. People don't actually steal it, we lose it. Now what happens? I borrow it and I leave it behind the sink, the 12 lead cable here, and that's it. And if you want one, you don't know that it's behind the sink. In fact, we have people that get so bad hoarding them. We found a stash of equipment in the tiles of one of the ceiling in a nurse's lounge because the nurses didn't want to be stuck having to wait for it. They sort of hoarded it at a level. The result is we replace it, so it gets lost within our walls, and so the idea is to tag this stuff with RFID and to know where it is. So if you want a pole, you can go in and see there's a pole within 5 feet or within a room, et cetera. This is the economic analysis. That says if we actually drop the loss rate, you can see the current loss rate in the fourth column from the right, the target loss rate, and that might be worth $300,000 of these particular items. This sucker, this is a technical term, sucker, appears to have a spectacular return on investment of getting RFID into place. Nonetheless, there are a variety of technical issues that go with that. One, we'll get to this quickly. This is an example of just using a PDA to record charges, amongst other things, and what you can see is improved revenue up 20%. That's not bad. And improved cash flow because it's quicker to get the service recorded and into the computer, so there's an economic gain to having that along with the convenience factor of looking at data. Now, there are technology issues here, so if we go back to that diagram of the nurses on the Mass General, say, what would you like this device to do? And what's be the ideal device? You see the list here. I mean, there's some phenomenal stuff. I love my favorite's the one on the second from the bottom. Interrupts gently when a call comes through. I don't know how that happens, but nonetheless, interrupts gently. And then you can put it in the dishwasher, and it still works on the bottom there. But if you look at these, and these are reasonable. Sometimes you get so Star Wars-y, it's not particularly fair. These are reasonable requests, but it does not exist. You cannot buy this at this point. And so a lot of work about what's the closest that we can get to this kind of technology. So we're limited, at least in this environment, from the devices that are available. The second, this is a highly noisy sector. We right now are deploying 3 infrastructures at the Brigham and the Mass General: an 802.11 infrastructure, a cellular infrastructure, and an RFID infrastructure, all of which require management and access points and a variety of things to deal with, and a fair amount of redundancy and overlap. So we have a incoherence of infrastructure, and in places like RFID, the tags are still too expensive. There are no standards for tagging equipment in the healthcare setting, and so we have to create our own standards for dealing with this and sorting through the technology stuff. Last point, and I'm going to come in right on time, Shirley, just to show you. What I wanted to point out here, and then the second slide, these areas of looking at remote provision of care and of the use of wireless are quite important to us, and not just to the institutions that Partners represents, but to institutions broadly, both certainly within the states and I suspect globally. And as being academic institutions, we devote time and energy to this. This is from the site of the Center for the Innovation of Medicine and Innovative Technology. And the guy whose picture is on the left, John Goodtog, who is the head of the computer science department at MIT, has working with us to develop a program on network sensor systems. And so these are a little further out as to understand the sensor networks and the sensors themselves that would be necessary in the 5 to 7 year time frame. So a lot of advanced work being done. On a more immediate basis, I have a very large IS group. Just to let you know, it's a incredibly effective, extraordinarily efficient IS group, but nonetheless. And we devote approximately 6% of our IS dollar to internally funded research projects to investigate topics. And so we actually fund investigations in a variety of these realms. And these are some of the projects related to the work that I've described. So in above and beyond being of interest, there's actual effort being devoted both on our part and I know your all's part to pursuing these. So with that, I will stop, and I look forward to colleague commentary and questions from you all. Okay.
What we're going to do is, it's going to be a little bit hard to have this happen, but to see how it goes, is ask the panel members to comment on any of the aspects of this. We're particularly interested in those things that go beyond the current. So maybe I'll start with Paul. Do you want to have any comments?
Well, as usual, John is incredibly illuminating. He does set up one of the most innovative and one of the largest healthcare IT organizations in the country. He's really been in the leading edge. So a lot of the things that he's talking about is clearly front-leading and visionary for the future. So I completely believe in this remote. I'm going to talk a bit about this remote patient connectivity and the ways that we can reach out and monitor diseases on a more continuous basis than just this episodic once every 50 days kind of thing.
Now, the only issue, by the way, is we're trying to record this, so it might need to be some way which we hand the microphone. Do we have that hand microphone? Yeah. Okay. This might help. Any comments on that, John? Yes. I know, but it's down the other end. Okay, good. All right. Other comments? Shankar?
John, I mean, absolutely outstanding presentation, and I would like to focus on 3 issues that came up from your presentation. The first one deals with response times in telemonitoring. If you're doing monitoring, what is your anticipation of the difficulty in response times being slow versus fast, and do you observe any consequence of the time factor in responding?
Well, I think, Shankar, we've been cautious, and you could argue whether our sense of cautious is true cautiousness. If there is in a sense that that in a very brief period of time, an hour or less, or maybe several hours or less, you could go from being okay to not okay. You shouldn't be home. We ought to have you within the walls where we can assemble. So one wants to monitor things where you're looking for change within 24-hour period of time. And so that even if, and one shouldn't expect that a signal takes that long to go from point A to point B. But nonetheless, you're looking for events that move over that period of time rather than things where you could fall apart suddenly. Because if that's the case, you should not be on this kind of stuff. So you can tolerate latency issues of multiple seconds, multiple minutes. It's hard to believe you'd actually get latency of hours on some of this kind of activity, and that there would be a way of finding you and getting a professional to you should we need to do something relatively. Even congestive heart failure is generally a deterioration over, it's not an hour deterioration, it's multiple. It can be a day before a real change occurs.
But this is a judgment call. The question was do you have protocols that define the degree of seriousness, the degree of...
Not in a multi-purpose sense. So when we, for example, our first work in early discharge post-operative was with breast cancer. People just had a mastectomy or a tumor removed. And there was up to the oncologist working with some patients to determine when post-operatively you could be sent home and what should be sent home with you. So it is in consultation with the clinical leadership that we arrive at the sort of rules of the road for this.
My second question deals with invasive versus non-invasive monitoring.
Mm-hmm.
In the case of, the glucose monitoring that you mentioned, it was obvious because you could have a wristwatch around you, which could, wristwatch-like devices could monitor it. What if you have do you anticipate in the future more invasive monitoring happening, like growth of cancer, for example,
mm-hmm.
where do you have, or congestive heart failure, for that matter, do you have invasive monitoring being playing a role in terms of healthcare needs?
Well, I can imagine that, although if I had a room full of sensor people, my guidance would be to avoid that as much as possible, because one is you have a sort of, even some form of a surgical thing going on here and some form of need to replace or to deal with that, and some possibility of body interaction and rejection. So to the degree you can apply it to the skin and wear it, so to speak, I would clearly want to do that for a whole wide variety of reasons. So that would be one piece of advice. The other piece of advice is fundamentally, at the end of the day, there's this huge consumer market here, and that's where one would like to go in addition to the professional market. So getting into this consumer class pricing schemes and service arrangements would be another thing that I would look like. So there may very well be invasive activity. Right now it is dealing with, to the degree you can, is leveraging stuff you don't have to invent. You don't have to invent the cell phone with a camera. It exists, and the resolution is good enough to take pictures of certain classes of acne.
And my very last question deals with a fairly complex and difficult subject, which is if you're just monitoring one single variable or parameter, it is very straightforward for the information to be processed in a more appropriate way. But imagine, 10 years down the road or 20 years down the road, you have the complete information on a patient. The patient's, communicating with their physician for the first time, for instance. Mm-hmm. The physician gets to look at the entire past history of the patient, as well as the physician communicates back with the patient on instructions. This requires a lot of structuring of information in some way that is non-controversial and ambiguous and not difficult. Are there efforts in your healthcare system, for example, to think seriously about structuring this information in meaningful ways, in structured ways, so that there's no ambiguity about both loss of information as well as the accuracy and the homogeneity of information?
Yeah, there's a fair amount of methods work or algorithm work. And one takes some steps that says one doesn't need to measure all sort of waveforms coming out of a body. There are certain areas to focus, because it's not as if we walk in with no clue at all about what might be wrong with you or what is wrong with you. So you can actually target, knowing that there's a neurological issue or an oncology issue, et cetera. But nonetheless, having done that, there's a fair amount of method work. And surprisingly, it comes in the areas such as RFID. If you were looking for an IV pole, how would you know that it was in use or not? It depends on how close you think it is to the bed to be used or not. And so if it's 1 foot away from the bed, it might be in use. Don't go looking for it there. If it's 5 feet away, it might be available for use. And so you even have to get into some distance and sorting through on methods of just locating stuff and knowing whether it's available. So I think here, and in particularly the area you're going to talk about in the bioinformatics, a phenomenal amount of methods work, algorithm work that needs to go on.
John, I enjoyed your talk as well. I was particularly fascinated when you brought up the topic of home-based healthcare, because I believe that in the next few years there's going to be a major shift towards healthcare provision at home rather than in the clinic or in the hospital. Yeah. And it raises a number of really interesting issues. As you know, the Department of Veterans Affairs, because of its sort of unique model, at least to the U.S., although it's probably very applicable in Canada, has an interest in minimizing healthcare costs in general rather than just episodic care. And so it's particularly interested in home-based healthcare. One of the things that we're struggling with is integrating the healthcare enterprise within the hospital, just trying to get the many islands of information systems in the hospital to communicate. There's a lot of emphasis that's being put lately with Brailler and the national healthcare infrastructure on trying to establish means of having hospitals with electronic medical records communicate with each other and to sort of have a global record. And it seems to me that once we go into the healthcare environment, you've got one additional, even higher level of complexity, because now we're acquiring information at home on a patient that doesn't really belong to any particular electronic medical record, given that a hospital may be seen by more than one facility. And so I'd just be curious on what approach are you all taking towards integrating home-based healthcare with your electronic medical record? Are you, for the information that is being acquired for patients at home, is that going into partners' electronic medical record? And what are your plans for the next few years for that?
Well, I think Elliot, I mean, I have, my youngest kid has 7 more years before they're done with school, and then I'm going to retire and forget all this nonsense here. But I think we will live with a high degree of integration and perfection in this industry for decades. I mean, there's just not a chance we'll ever integrate all the islands and ever integrate everything across the country and ever integrate all the sensors, et cetera. It will be this phenomenally imperfect thing. And there you go. Because there will never be a reason, utility, or ability to do it at a scale. Sort of background question, response. The other is when we do a lot of the monitoring, we do not view this as long-term retention of data. This is like reading blood gases in the ICU. They've got a transient value. While you're in the ICU, they're enormously important. 2 days later, they're irrelevant, unless some crisis occurred in which you can sort of carve out an interval of time. So a lot of this data is purely monitoring, has very limited value, and never winds up in the electronic medical record at all. What will is if there's a nurse visiting you and making observations and taking snapshot findings, and so there will be slices of it that wind up in the record, generally at the judgment of a healthcare professional, but we don't do the full integration because it has, generally in our view, the record ought to have durable utility. So your allergies are valuable knowledge for the rest of time. The fact that you had a surgical procedure can be valuable for the rest of the time. The fact that you had a medication, discontinued it can be valuable, and a lot of this has no durable utility, so it goes off to archive. I'm not sure we ever retrieve it at all.
In our system, we're trying to integrate it with the electronic medical record. So we have patients who take glucose measurements or measure their weight or other vital signs, and then it ends up going into the electronic medical record, but the data is not entered directly in the hospital or the lab. It's somewhat suspect, and so there needs to be a way to sort of partition what was entered at home versus the information that we educate the patient. So part of the home-based healthcare is patient education for diabetics and other types of patients, and that is documented in the healthcare record. But that's in an environment where patients tend to go to one hospital or one system. It'd be interesting to see how that happened across multiple systems.
Well, I think, Elliot, in the same problem of what Paul sees in his portal out to the patients, if a patient records a problem, do you trust that? That it's an accurate statement of a problem versus it's sort of a pre-fact, and that a physician actually needs to turn it into a fact.
So time for another brief comment from Don. I'll switch to the other.
Okay, great. John, thanks for the talk. The question I had was around similar things for remote care. Just a couple of questions since we're thinking future-wise. If you look back, some of the stuff, seeing the work that we've done there, made an awful lot of sense even 4 years ago. And I would ask, is it the technology that's been holding it from going into the home? Is it more of a financial or a business model issue? Is it resistance from physicians or from patients? And it's not so much, say, the cell phone technology that I saw, but when the Internet came out and the number of people had access to email, I thought for sure everyone was going to start to see their physician over email, and there was a big delay to that adoption. With that as a premise, what do you think is going to happen over the next 5 years with all of this?
Well, I think, Keith, all of those have been issues, but largely it's been the business model has been non-existent. And so, a guy like Paul Tang here who sees patients, why do I want to put up with this nonsense of people coming through the Internet because it's just extra work? And so what's in it for me? And we've had a lousy answer to what's in it for me. I think the business models are unfolding, not necessarily quickly, but unfolding. And part of what we've done is to find alternative models. And I'll give you an example of an alternative model. We just spent in the last couple of years an amazing amount of money. I mean an amazing amount of money building new buildings to increase inpatient and outpatient capacity. And the board chair says, I can't do that again. I don't know that we'll be able to fund that kind of maneuver within the next 5 to 6 years. Can we get 10% of the volume out of the house and drop my ability to need to add new capacity? There's a business model in there where you can actually do an assessment based on this thing. So I think we'll have traditional models of reimbursement. We will search for new models, whether they're retainers with employee, Fortune 100s or consumer purchase of activity, to things like I just mentioned before. There's always a need for the technology to get easier and better, because at some point it gets so inexpensive and so easy to apply, it is in the consumer realm. And then you bypass, you sort of move into a new zone entirely and make it a lot easier to use. There are always issues of people picking it up, of the healthcare profession adopting along those lines. But I think the business model is the one that's been the biggest issue, although I do see that changing.
What I'd like to do is open it up to comments. We're trying to recover a little bit of the time that we lost at the beginning, so we keep on spec here. We've got people at either side, Phil at this side, and David over there to give a microphone. So if you have a comment or a question, could you just give us a chance to get to you to get that on microphone? Phil on this side first. Okay, you're number one. And then I'll switch.
Since I'm close to the microphone. I had a question about the teledermatology and the e-consulting that you were doing, and how do you get reimbursed for that? And I'm in the military, and we don't do direct reimbursement, but we do have workload credit issues, professional, and also for the consultant, the person on the transmitting end for capturing the images and storing them, and the challenges there, since they're not DICOM yet. So just wondering how you charged for those e-consults and telederm to keep the program up and running.
Across the categories, the second opinion is consumer out of pocket, $600 you pay, and we get that, and that actually is a viable consumer good. The second is a retainer basis for Fortune large companies, and that tends to work in both cases, reasonable enough volume to sustain it. The notion of a telederm or things along those lines, business model is rough. We are running analysis to see whether you take that volume out, replace it with higher RVU volume, whether you can net up as part of the practice. But I'm not sure where it's convincing enough to see that at scale. And as you perhaps know, the payer interest in this is still hesitant and shaky. So I think that's in some ways the least well developed, where the primary care provider is interested in a specialist opinion. Certain exceptions, radiology is an exception in the States. Nantucket Island is a rural, underserved area according to the Medicare, which is striking. But nonetheless, we can get paid for doing teledermatology to Nantucket Island, telestroke work to Nantucket Island. In the stuff where you're talking to your physician through the internet, Blue Cross Blue Shield of Massachusetts now pays the doctor $24 for a visit along those lines. It's good enough to get interest, but the adoption rate is slow, largely because consumers don't know what to do with it, and doctors are hesitant to push it and to really do this thing. So we have models in a couple of the categories, and where some categories issue is sort of getting used to it and seeing what the right level of use is. But I think in a lot of the primary care provider to specialist is still problematic in terms of a real civilian sector reimbursement model.
Comments from the other side there? Put your hand up.
Hi, my name's Don Cowan. I've been in this computer science game since before it was invented. And I like your talk a lot, and I'm doing a lot of the same kind of thinking you're going through, although not with the experience you've got. But one of the things that bothers me is delivery of healthcare is very much a social process. And I'd like to hear people's comments on that, just how we can do a balancing act here, because quite often somebody comes in to see you, you discover something that isn't even related to their complaint.
Right. Oh, I think it's, we could have a probably separate day-long discussion on the social aspects of this. One is the fact that it's a social economic good. It's like education, et cetera. It's got to follow. It can't go insolvent, but on the other hand, it has a social mission where it does things which are stupid economically to go off and do this. The other is the social nature of the relationship between a provider and their patient. It's not a service relationship. It's an agency relationship, which has different tones of what is this relationship really, what's the degree of trust, what are the mutual obligations, et cetera. I think society's goofy. You know, on one hand, we have a lot of people worrying about their health and all, you know, I'm going to get this and the other. On the other hand, certainly in the States, the obesity rate's going through the roof, despite all the data that would suggest that that's lethal in a lot of different ways. It's sort of this sort of unbelievable ignorance of the fact. So as a psychological, social psychological, like a social economic system, it's complicated as hell. I think, you know, you get into conversations about why is healthcare behind. Well, it isn't behind when you consider it's actually vastly more complex than any more other industry, and largely what's behind is our answers to this. They're primitive. They're too darn primitive to, in fact, be effective, given the complexity that we face here. So all of that is borne in mind, and you see flavors of it throughout, I'm sure, all of our presentations of the social mitigating factors, whether it's doctor adoption or patient adoption, or people unclear about how to reimburse because they don't know what sort of economic condition they'll create. They want an end-stage renal disease fiasco all over again, and a variety of things like that. It makes it kind of interesting, but it certainly makes it complicated and hard, and the pace of adoption quite slow at sometimes.
Over the side, comments or questions?
Here, if according to your experience, if I actually now a hospital have a well-equipped infrastructure already for their information systems, now I want to add this home, like a remote care, a home care for my patients. Is that really put a lot of burden on the infrastructure of the hospital, require lots of investment upfront? Is there key technology, like a obstacle preventing the hospital on more aggressively pushing the adoption?
I think you could have lousy infrastructure and do a lot of stuff here. You could have terrific infrastructure and do the same amount of stuff. So it is not as if one has to get to a point and then one's ready to go off and do this, because largely the internal infrastructure is not the issue. The issue will be whether the business model is viable and sort of the economics work. The issue will be whether your physicians or healthcare teams view this as an important adjunct to the work that they're going to go off and do. The issue will be, you know, for both the IT group but also the professional group, they know how to support within the walls. Now you're covering a broader geography. You're going into people's homes, and you're dealing with, you know, gizmotree, you know, all that sort of PlayStation nonsense that you saw up there. So there's a support model that's different out there, and they may or may not know how to handle a support model along those lines. So I think the challenge will be, is the money okay enough? Is this clinically the right thing to do? And if we go off and do it, can we support it? Both technically support it, but also support, you know, the person who wakes up at 2 in the morning and is alarmed because something's beeping in their home or whatever that might happen to be. So if you can respond effectively to all those, regardless of whether you're at an A+ or a B or a C of your internal infrastructure, I think you can sort of sever those two conversations.
Question, David?
I'm a family physician and also an engineer, and I'm curious about most of the things you put up were on the cutting edge piece. In hospitals particularly, where so much historically has been run on the dollar in terms of everybody's responsible when it comes out, has the IT process ever got involved in more monitoring about the use of technology? And what I'm talking about, I had a case this last Friday, won't get into the details, except that I'm 2 good stone throws away from a large teaching hospital where my clinic is, and I had a woman who I was concerned about an ectopic pregnancy. And it was easier for me to get the patient to go to another place and get the stuff back to me fast so I know what was going to happen to her than it was to use a large, and there's only 5 of them in this province, a large teaching hospital. My question is then, is part of the new IT role to look at how information gets put through in the clinical paradigm and not just rely on the local clinical floors, units, whatever, to be upfront about it. In the same way, we wouldn't allow a floor to be out in the open about finances. We would force them to conform to some kind of standard. Do you get involved in that?
Well, I think it's quite variable across organizations. To what degree the IT group is, quote, progressive. You know, and progressive might mean an umbrella term for going out of their way to look for opportunities to apply the technology and sort of putting ideas, rather than just waiting for the phone to ring, and looking hard at new technologies and new ways to improve care. you'll see the spectrum of groups that are and groups that are quite, if they feel in battle, and they just want to do the least they can do to get by the day and not get beat up and do this. So I think it's quite idiosyncratic, and in a way it's unrelated to whether it's academic versus community. There are some phenomenally progressive community hospitals, and there's some phenomenally unprogressive academic settings. One of the odd things about, I think, healthcare is you can do a lousy job and not be economically punished. I mean, it's sort of rare in the industry where you can do a lousy job and get away with it for a prolonged period of time. So we can deliver lousy service to you, and, it's striking to me, Mass General, I love the Mass General, but service ain't our game. So we abuse you, we make you wait long times, et cetera, and you still show up. It's amazing to me that continues to go on because you want the best doctor on the planet, and little do you know that we really don't have them and this kind of stuff. So, but I think part of the reason for pointing that out in the IT group is that there's less of an organizational imperative at times to go off and look for all this stuff because it could be viewed as a distraction, a movement of expense dollars into a terrain for which there may be no economic upside. And so I think that's part of it factors into the normal variability of progressiveness, but there's also an industry economic dynamic that, in fact, may skew it one way versus the other. So I don't have a better answer for that other than to say it's highly variable.
Questions on this side or comments? Anybody else? Okay,
Don't you think there is a contradiction between using remote devices and home healthcare and versus community healthcare? Because many hospitals are trying to tie their patients giving services, but both technically and commercially, these are not compatible ways of doing healthcare. Because if you tie your patient with a remote device that only speaks to your system, you're even blocking real community healthcare and community healthcare, so between enterprises and regional healthcare.
No, I think that's fair. I mean, we believe that if you have a chronic disease, or I do, that we will point to a provider, a person who is our point of contact. And it could be a visiting nurse, it could be a cardiologist, it could be an endocrinologist, but nonetheless there is this person who is at the pinnacle and represents that. So we want to make sure that whatever we're using at home is tied to them because we're relying on them to orchestrate subsequent activities. Now, that may sort of bind us in a way to one organization and sort of remove a community asset. What's unclear to me is and that's, you're right, a counter to the fact that I might move around and see multiple providers during the course of my particular stay. The only response that I have to it is that the organizations make the investment. And so I'll make the investment on behalf of you, the doctor, to go off and tie to your patient. I don't care whether you're in an academic medical center or a community health center, but we'll make the investment. Certainly in the States, communities don't make investment. Organizations within communities make investments, and they make investments that serve their interests. If it's easy enough to collaborate with others, they'll do that, but if it's too hard, they won't bother with that. I think it's part of particularly in the States, the Brailer federal initiatives, can you level that field? But right now, it does not solve or advance the community notions because you have independent organizations making conflicting decisions, all intending to do the same kind of thing, with the resultant fragmentation of care that will clearly result and wasted sort of redundant investments.
Glenn?
I'm just wondering, as you take a look at the remote monitoring piece, both for acute patients and for chronic patients, if you've had discussions around patient empowerment and patient accountability, that working on both sides, and how in your research and in your teams looking at rolling out some of these applications or using some of these applications, how patient accountability plays into what you're doing.
Oh, I think it's essential in a lot of this stuff, and those of you who are in this setting know how variable that is. I mean, there's, you could argue multiple classes of patients, those who will assume that responsibility and work very hard with you to do the right thing. And then there are those who will be, sort of uneven about that, in and out, off, on and off, uneven about that. There are thirds who say, I just can't deal with this. I'm just honestly overwhelmed and I can't handle this kind of stuff. And then there's a fourth who believe they're immortal, generally teenage males, but it certainly extends well into middle age here, and nothing's going to happen here. So it's a complicated dynamic about assuming responsibility, and you see that in other lifestyle factors, obesity and drinking drinking and driving without seatbelts and a variety of other things here. What's striking to me, too, is the value of that dwarfs the value of the technology. You know, an example for me is my brother lives in Alaska, out in Moose Pass, Alaska, which is right near Bob's Knife Shop. You know, if you've ever been up to Alaska and find Bob's Knife Shop, you'll know where my brother lives. But my niece has asthma, and I was up there a couple summers ago, and there's Mom working with niece to take, measure the forced vital capacity, take the drugs, and record a bunch of numbers on a 8.5 by 11 piece of binder paper. And you could see the entries every day on this 8.5 piece of binder paper. Monthly they went into the doc. The world doesn't need technology, it needs moms. I mean, fundamentally was my conclusion coming out of that as someone who really took the time and the burden to go off and do that. So we can help with the technology, but man, we are secondary to exactly the point that you're raising there.
I'm trying to recover some of the time, so I'll have to ask, we'll end it now. I've heard John speak many times, and the presentation is always great. My only regret was only having 20 to 25 minutes for you to entertain us, so thank you very much.
My pleasure, Dominic.
Yeah. So what we have now is a break. I'll ask you to be back here sharp at 20 past, and we'll have recovered all but 5 minutes, and then we'll go on with the next speaker.